Good evening, everyone. I'm Dr. Kaladhar, head of the Department Critical Care Medicine from Yashoda Hospitals, Malakpet. So, welcome to our Tuesday Masterclass webinar, which we conduct regularly. And these sessions on alternate Tuesdays are very well received across, especially because the students from diverse institutes they present, and the senior seasoned teachers they regularly engaged with these discussions and give directions to our students, and very much like they basically share their clinical experience and insights in these classes. So overall, we got so many feedbacks telling that these sessions are too useful for their practice, and even students while going exam they look at these videos as the reference. So with this, today topic of discussion is acute pancreatitis. So we do see these patients very regularly. Once they come to ICU, they are most of the time sickest patients, which initial period of the time, the resuscitation and finding out the etiology and working up accordingly is very important. And day in and day out, we do see these patients very regularly. So to discuss this, I welcome the senior seasoned clinicians and the examiners, Dr. Suhasini Madam. So she's having a vast experience. The background she came from the NIMS, which is a premier institute in our Telangana state. So, and worked across different corporate hospitals and even medical college setup. Madam having a vast experience gives very good clinical insights, and we do look at her regularly, like in the lectures and all. We do see a lot of very good material, and we look at her as a teacher, as a senior teacher. And I welcome Dr. She's a professor and head of the Department Emergency and Critical Care Medicine in ESIC Medical College in Hyderabad. So I welcome you on board, ma'am.
Thank you very much.
And I welcome Dr. Durgesh. He's a senior consultant critical care medicine from Yashoda Hospitals, Secunderabad. So he heads neuro ICU there, having a vast experience across the all ICU cases. I welcome you, Dr. Durgesh.
Thank you, Dr. Kaladhar. Indeed, it is a privilege, and what we started in Yashoda Hospital Group, that this is a critical care master classes. Because these are not only clinician, these are very important for the exam going student as well, because lot of important topics had been covered, like ARDS, sepsis, a lot of complex topic like brain dead declaration, what are the clinical complexities in the brain dead declaration. So if you go through all these video, you can you have a complete bank of for your to prepare for the ongoing examination. And not only for examination, even if for day-to-day practice, all the senior teachers, what they experience, the thought process, it is quite engaging, and we can extract lot of knowledge. It is really helpful, I think, and it is very well received across our whole country, and everybody is looking forward to join and to listen these classes.
Thank you, Dr. Durgesh. Dr. Venkat Raman Kola sir is also there. Sir joined. It's a brainchild of these programs and all. He keeps on behind us, and he elevates us, and even is behind these programs, always encourages, motivates us. Venkat Raman Kola sir.
Thank you, Kaladhar. Thank you, both of you. Suhasini madam, we have been waiting for your moderation and class, ma'am. And thank you, Durgesh, for accepting. We'll go on to the case, Kaladhar.
Thank you.
Okay, I welcome Dr. Avishek and Dr. Nikita. Both are DrND Critical Care Medicine students from Fortis Escorts Heart Institute from New Delhi. They came forward to present the case so that others will have their experience. So Dr. Avishek and Dr. Nikita, you can go ahead with your presentation.
Good evening, everyone. So myself, Dr. Avishek, and my colleague, Dr. Nikita, we are going to present a case of acute pancreatitis, which we came across in our institute. So we had a patient, 46 years male, and he was admitted to our institute on 7th of January 2024 with chief complaints of pain in upper abdomen for 1 day along with nausea. So the history of present illness goes like the patient was apparently all right one day back. Then suddenly he developed pain in upper abdomen, which was severe in nature, sudden in onset, and it was radiating to the back. The pain doesn't aggravate or relieve with change in posture. He also complains of nausea, but no vomiting. He had no history of cough, burning micturition, loose stool, hematemesis, melena, acute loss of weight, no insect bite, or any intake of unknown or herbal medication. In the past history, there was no similar complaints, and he has no comorbidities, and there is also no history of any surgery or any hospitalization in the past. His personal and family history includes normal bowel and blood habits, and his last bowel movement was yesterday, and it was 2 times. Urine output was adequate. He takes mixed veg and non-veg diet, and he has no history of any alcohol intake, although he is a chronic bidi smoker, and he had been smoking for the past 20 to 25 years. He is married, and he has no significant family history, and there is also no history of any travel or food intake outside. So the general examination, the patient was conscious oriented. His GCS was 15 by 15. He is moderately built and healthy, and no pallor, clubbing, cyanosis, or icterus. On inspection, like he looks dehydrated, and his pulse rate was 103 per minute, and BP was 110 by 70 millimeter mercury, and saturation was 95% on room air, and respiratory rate it was 18 per minute. Temperature wise, he was febrile, and blood sugar level was 166 milligram per deciliter. So on the focus, we did eyeballing, and then contractility of the heart seemed okay. IVC was 1.6 centimeter, and it was less than 50% collapsing, although the patient was spontaneously bleeding. And the lung ultrasound showed a profile, and we saw no free fluid in the abdomen. In systemic examination, we started since it was an upper abdominal pain, so we started with the GI system. On inspection,
Suhasini, ma'am, do you want to interrupt? Dr. Durgesh.
So, what you are thinking and what you are looking at, what could be the from this information, what you can gather? Previous slide once.
The patient had upper abdomen pain, and it was for 1 day along with nausea, and it was severe in nature and sudden onset, and it leading to the back. So the first differential diagnosis that I will keep in my mind, that the abdominal causes I'll think of first, then along with extra abdominal causes. In abdominal causes, I will think of peptic ulcer, perforation, or any hollow viscous perforation, or obstruction, or acute pancreatitis, then cholecystitis, cholelithiasis, hepatitis, and liver abscess, then mesenteric ischemia, and appendicitis.
So, like,
Okay.
yes, ma'am.
Go ahead, Dr. Durgesh. No problem. Go ahead.
Because
Madam, if you want to ask questions, yeah, I can go ahead, ma'am. From first slides.
No, it's okay. Like, let Durgesh know. Go ahead. No issues.
Yeah.
Durgesh, go ahead.
Both of you.
So very like to have has totally no any comorbidities, no any alcohol history, nothing, just presented with the pain in abdomen. Very like unlikely to be having. Suppose presenting with the pancreatitis case, what are the two most common causes of the pancreatitis in our country? It is either ethanolic induced, or it is as mostly it is secondary to gallstone pancreatitis. But here not much of to be exactly suggestive of that is going to the any abdominal pathology.
Yes.
Okay, go ahead. While next slide. Or more, next slide. So, for sake of discussion purpose, what is EPSS?
EPSS is an endpoint systolic
It is endpoint
septal separation.
What it indicates and
It indicates the contractility of the left ventricle.
okay, so because you have mentioned here EPSS, it is just a very rapid method to just know whether your ejection fraction during patient it is normal or not. Usually, you have a plaques mode and you can see put M mode through the mitral wall leaflet. If it is touching to the left ventricular wall, then you are dealing with the patient having adequate or good ejection fraction. That will it will tell us. So that is an EPSS. So and IVC collapse with any other marker, echocardiographic marker, you can uh, see in these kind of patients who are spontaneously breathing and to assess whether the patient is fluid responsive or not.
We can see the contractility, the eyeballing.
Velocity time integral, have you heard of?
Yes, sir. We can.
So yeah, so look, the if many times what we see, even though like spontaneously breathing patient, uh, not this case who is comfortable or breathing and all those patients who are really hypoxic and who had got high respiratory rate, the variation itself is goes high. So there are high chances of false positivity in case of you are going IVC. So if you are well versed with the echocardiography, you could have a velocity, you can calculate the velocity time integral. So that is one of the method to see whether the patient might be fluid responsive, and there are adequate data to suggest that it can be used in spontaneously breathing as well. So you have to have 5-chamber view. You can put a pulse wave Doppler and you can measure the velocity time integral, and you can put the aortic opening as a diameter. You can put a pi r square h, and by this doing this, you can see whether the patient is fluid responsive. Okay.
So what is the other use of ultrasound in this case?
We can, ma'am, we can do the lung ultrasound, then we can do the focus. Then a focus we can see if there is any free fluid in the abdomen or not.
Free fluid in the abdomen, or you're more concerned about something else, as in this particular case, like where you are suspecting pancreatitis, where there's no history of alcohol, and then the patient, you need to evaluate the etiological cause.
We can look for gallbladder stones.
The gallstones are really nicely viewed, and then it's more sensitive to be examined by ultrasound, isn't it? The first assessment is ultrasound, evaluation of gallstone. All right. And then when do you do a CT scan of the abdomen?
CT of the abdomen usually we do after 72 hours. It is indicated for 72 hours because we will have to do the resuscitation, and also it takes some time, like some minimum 72 hours as per the studies, for the development of any pancreatic inflammation or any edema or any necrosis.
But in this case, do you think it is necessary to do the CT abdomen?
It is not necessary if the patient is improving clinically.
So here, you don't have any clue, what did you find on the ultrasound? Did you see any gallstone?
No, we did not find any gallstone or any cholelithiasis in the ultrasound.
Okay, fine. So please proceed. And then you fluid resuscitated. What's the type of fluid you want to give?
Crystalloids are the choice of fluids. Balanced
Yes.
fluids. We use RL for resuscitation in these patients.
RL is if we have to choose between RL and NS, we should go with RL. But in our patient, since we have institutional protocol, so we have used plasma light in this patient.
So RL, is there any difference between plasma light and RL?
Yes, ma'am. There is a slight difference. The pH of the RL, it is around 6.2 to 6.5, and the pH of plasma is 7.4. And this plasma light is also more physiological because the osmolarity of the plasma light is around 290 milliosmol per liter, and whereas the RL osmolarity is 270s. I mean precisely 274.
Yeah. Okay, it's slightly hypotonic. And then when compared to normal saline, which is better, like, you think, and then what's the problem with normal saline, like, resuscitation?
In resuscitation, we use large volume of fluid. So if the patient is already having acidemia in the ABG, then the patient might land up in hyperchloremic metabolic acidosis.
Okay, fine. So what are the other lab investigations you want to send in this particular patient, like, where you have to diagnosis in terms of establishing a diagnosis?
Okay.
What are the other labs you want to send, or like, what are the other investigations you want to send?
We will do the basic lab investigations, like complete blood count, then the kidney function test, then liver function test, along with serum amylase and lipase. Then we will also do if the like if a patient is young female, then we can do urine pregnancy test. Since our patient is male patient, so we didn't do that, and we can also do the chest X-ray. I mean, a chest X-ray as well as X-ray of the abdomen.
X-ray of the abdomen. Why did you think so?
X-ray of the abdomen, since we are not sure, we did not receive our lab investigations yet. So, and the patient has upper abdominal pain, so we will try to rule out all the possible causes.
Like
Okay, fine. So, so what are you expecting in the labs? Like, in this particular case, and then, like, how are you going to proceed further in case it is a pancreatitis?
for pancreatitis, according to lab values, you will see for amylase and lipase, there would be 3 times the rise than the upper normal limit value.
Amongst the two, like, amylase and lipase, which is more specific, and you, like, if you don't have, pick and choose one, then what do you choose?
Lipase is more specific for acute
pancreatitis. Okay. So can you tell, like, why lipase is more better than amylase?
Lipase, ma'am, it starts to rise early, like 6 to 8 hours. Then it stays for a longer period of time, 10 to 14 days, and also it peaks by 24 hours. And the study shows that it rises more specifically in only in pancreatitis, in acute pancreatitis, although it can rise in other conditions as well.
Any bedside test, like, marker, like, you can do for establishing the diagnosis of pancreatitis and early pancreatitis? Urine dipsticks,
Yes,
though it is not done in India, maybe.
Yes, we can do urine trypsinogen test.
Okay. So the urine trypsinogen, is it better or is it more sensitive than lipase or equal to that of lipase?
Lipase is more sensitive than urine trypsinogen.
So what are the dynamics? Like, how fast it rises and then how long does it stay positive? That's a disadvantage, isn't it? Yeah. It stays only for 3 days. So beyond that, like, 3 hours, I mean to say 3 hours. Beyond that, it, like, it may not show up. Like, so early diagnosis, maybe it is useful and it is as sensitive as your lipase in the bedside diagnosis. All right. So, okay, please go ahead. And then, like, Dr. Durgesh, you have any questions in this until now? And then what's the other test you want to do?
Lipase, like, it is more specific. Amylase has a lot of other sources from where it can increase in the. So lipase is more sensitive 3 times than the normal, and suppose in diabetic patient, probably more than 5 times for the diagnosis of pancreatitis.
So what are the other tests you want to send?
You can send for a lipid profile also for this patient.
Yeah, because you didn't see any gallstones or like in the patient is not an alcoholic. Maybe you have to search out for lipid profiles. Definitely, yes. And then what else?
Yes, then there could be a rise in the triglyceride level could be in higher level, and also we can also do the calcium level.
Okay, so calcium level. Does CRP have any role here?
CRP, yes, ma'am. In acute pancreatitis diagnosis, it doesn't have any role, but if the diagnosis of acute pancreatitis already have been established, then there is a role of CRP.
Definitely. Yes, very good. So after like, it's a severe form, then the CRP starts to rise and it's an indicator of bad prognosis. Okay. So we have to, on day 3, we do CRPs. Okay, fine. That's great. So what else? Like, keep going. Lipid profile you sent and then like, as it come back, like all the investigations, can you go through?
So on the first day, the patient was transferred to the ward because the patient did not show any organ dysfunction and the patient was vitally stable. So, but the patient on the first day, he had a rise in serum amylase and lipase. And so he was on first day, he was managed there. But next day, he deteriorated clinically. So in view of deterioration, he was shifted back to the ICU.
Okay. So what are the various risk scores, like, where the patient needs better care and then like, definitely, how do you assess these patients in terms of using various risk scores?
In terms of scores, we have bicep score, which we can do bedside. Then we also have Glasgow Image Scale score, and we have Ranson's criteria.
And check for organ involvements. We can also do modified Marshall scoring system for this patient.
Okay, amongst all these scores, like, which do you think is very simple and it is as good as your, like, Apache 2 scores?
It is bicep score, definitely.
Bicep score. So can you elaborate on the bicep score?
Bicep score, it is a bedside index for to assess the severity of the acute pancreatitis. So we have a few parameters like the blood urea nitrogen, if it is more than 20 milligram per deciliter, and if it has impaired mental status, then if it's SIRS positive, then if the patient has age more than 65 years, and the presence of pleural effusion.
So in the X-ray on like the ultrasound, you have to evaluate for your pleural effusions also. Maybe in the early phase, it may not show up. Like, maybe as the days progress, maybe you have to establish the diagnosis and then see. So when do you call it a severe, how do you classify the pancreatitis per se?
There is modified Atlanta classification we use. It classifies pancreatitis acute mild pancreatitis, acute moderate pancreatitis, and acute severe pancreatitis. So when we talk about acute mild pancreatitis, there is only local inflammation of the pancreatic and peripancreatic area involved with no organ failure. In acute moderate pancreatitis, there is peripancreatic inflammation and an organ failure which is less than 48 hours.
Transient.
This is a transient organ failure. And then there is acute severe pancreatitis where there is peripancreatic inflammation along with the persistent organ failure which is lasting for more than 48 hours.
So very good. This Atlanta classification, like, it's a very much valid. And then to classify the patient into severe acute pancreatitis, then like, the organ failure. So in this patient, what was the indication for shifting into the ICU?
The patient, he started to have tachycardia, and it ranged between 140 to 160 beats per minute, and his BP also dropped, and BP was, when he came to the ICU, it was 82 upon 52 millimeter of mercury, and his respiratory rate increased, and it varied between 32 to 38. And saturation wise also it decreased, although on room air he was maintaining saturation around 90 to 91%.
Okay. Fine. So how are you managing this kind of patient? Like,
So,
when they come to the ICU?
okay, first we will assess the patient ABCD wise. We will see whether the patient is able to maintain his airway or not. Then we will look at his breathing, his saturation, his respiratory rate, and we will also auscultate. Then we will look at his circulation. We will look at his heart rate, his hydration status, the BP, then the urine output, and also the mentation, the GCS.
So do you think like the NIV application is justified here, like the patient is having problems?
Generally, in upper abdomen,
Yes, no.
NIV is not recommended to be used in patients like this. But we had to use NIV since patient attenders had financial constraints and were not willing for invasive ventilation.
And also at that moment, we did not have HFNC.
Okay. See, that's like, the patient's approval is also one of the reasons you can apply. But now in this particular case, is it justified, like, to putting on NIV because the blood pressure is only 82 to 82 by 52. So hypotension. Shock patients, like, usually don't apply, isn't it?
We should be intubating him and keeping him on a mechanical ventilation.
Sure, you should be present in front of the patient and then while resuscitating, and then you have to see whether the patient is responding or no. And then immediately you have to take a call. So in shock patient, if you put on NIV, especially with abdominal problems, it'll be a disaster. Sometimes they aspirate and then have a problem. So you have to be very, very, very cautious and then stay in front of the patient and then take a call. But otherwise, invasive mechanical ventilation is the better choice for this kind of patient. Okay. Dr. Durgesh, what do you think?
Yeah, absolutely, madam. Because I think what do you think? I'd asked Dr. Avnish, and what could be the reason for acute worsening? Because you see, yesterday the patient probably came in the evening and is relatively stable, and patient you were shifted to ward, and again there is acute deterioration. What do you think? What has happened?
The patient, maybe he was not well hydrated in the ward, and there could be also possibility that his pain was not adequately managed in the ward.
So the etiology of, if you see the pancreatitis, the main reason is extensive third spacing. So because of third patient might land up in hypovolemic shock. Now we are saying the focus is IVC is collapsing, lung is A profile lung. So I think there is a lot of third spacing has happened. That is why the patient might have deteriorated. So as madam said, NIV might be like very cautious and better not to put when there is some abdominal problem is happening. So be cautious if at all, go ahead with HFNC, or if still not available, straight away go with and secure in the airway, because this patient is having serious extensive SIRS response. So regarding scoring system, we already discussed like Apache scoring system, Bicep scoring system. Any other scoring system are you aware of?
Glasgow in this score.
Okay.
Then Ranson's criteria.
Okay.
Then there is also one score is Bali score is there.
Okay. Regarding simple score, SIRS response, if the patient is having severe SIRS response, like more than 2 factor is positive, then we should expect like severe pancreatitis and high mortality. One more bedside score, that is like very easy, and as soon as patient comes to you and you can see it with minimal lab investigations.
That is HAP score.
What is that?
Score. Harmless acute pancreatitis score, that is done to see if patient is presenting at the first time symptoms with acute pancreatitis. So we see for any guarding or tenderness is present in these patients. Then we see the blood urea nitrogen level, and we look for hematocrit of these patients.
Okay, very good. If it is not there, probably we are dealing with a mild pancreatitis case. If it is there, then again severe pancreatitis matters. Okay.
So biceps haven't.
Ma'am, can you please repeat?
Suhasini madam, yeah. You're
What's
breaking.
the advantage of biceps
Yeah,
over
now.
other things? Can you hear me?
Yeah. Now it's fine, ma'am.
Biceps score.
It
Yeah.
is, it is
In between, there is some disturbance, ma'am. Yeah.
Bicep score, like, the advantage of bicep score.
advantage of bicep score. It is simple to calculate, and we can do it bedside.
Bedside, and also, like, before the onset of organ failure, it indicates the severity. Okay, more than the cutoff of 2, like you can like early identify the patients even much before the onset of organ failure. You can identify the patients at risk. So that's the advantage of a bicep score. All right, and individually hematocrit, like, more than 44 also is an indication of risk factor, apart from SIRS, like, he was telling, and then the blood urea nitrogen, everything, like, it has, which shows that there is some organ failure, and then inadequate organ perfusion. That's what, like, is a one. And because of the third is probably in the patients, you have to be careful, like, interpreting. And CRP definitely, like, on the third day, maybe the patient has come to ICU now, like, you have to do CRP, and if it's very high, you have to, like, so it's an indicator of, like, bad prognosis. Okay. Okay, go ahead, please go ahead.
So after the examination of the patient, we started with the management. First, we secured his airway since he had respiratory distress. So we started an IV therapy on this patient. Then we started the fluid plasma light. First, we gave a bolus of 500 ml since he was moderately built. Then followed by another 500 ml, and we continued. We maintained the fluid at 90 ml per hour, and we titrated according to the need of the patient. And after that, the patient was not able to maintain his MAP more than 65, so we initiated norepinephrine at 5 microgram per minute, and again it was titrated according to the MAP. Then we secured central line and arterial line, and we also have secured Riles tube. Then we monitored his vitals and urine output, and his analgesia was taken care of by paracetamol and tramadol intravenous. So this is the first, the lab values on the first day of ICU. His TLC is within normal limit. His CBC is within normal limit, and kidney function other than creatinine, burn was 34 and creatinine was 1.9, and he was mild hyponatremic 134, and his LFTs were fine. Then RBS, it varied between 120 to 190 milligram per deciliter. Procal, it came higher value 6.1, and he had fever of 101 point Fahrenheit. And the first ABG showed, this is the first ABG when he came to the ICU. So the patient had metabolic acidosis, the pH being 7.29, then PCO2 23, bicarbonate was 11, and base excess was -12, and lactate was of 7.9. Here I have omitted the oxygen O2 level because the pH ratio here was more than 300.
This ABG had taken on what setting? What was he was on ventilated or what?
No, so the patient, when as soon as he came to the ICU, he was on oxygen high flow mask of 10 liter.
Okay. What are the PO2s you said?
PO2s, I said the pH ratio was more than 300.
Okay. So seeing this, what do you think? What could be the factor which has worsened, which has a prognostic significance in the due course of time?
Prognostic factor due course of time, the patient had increased level of burn and creatinine.
Okay.
And the patient had that the Procal level was 6.1, and he had fever as well. And also the patient he had metabolic acidosis.
And lactate level were also high.
So if you go to the scoring system, if you see the hemoglobin is 6, what could be roughly if you should take the hematocrit is twice that of the hemoglobin level. So his hematocrit has increased. So upper limit where the more than 44 he has a probably we are dealing with a severe pancreatitis, and the complication rate, mortality rate will be higher side. And other thing, we have got organ dysfunction as well. So creatinine level has increased to 1.9. Moreover, we have got other what? So lactates are also high. Base deficits is also increased. Okay, and the pH is also dropped. So all this will indicate there is, if you see the Ranson's criteria after 48 hours, what are the many factors you can see? You can see all of this. So this procal, I don't think it's infective. It is, I think, is an inflammatory marker only in this case. So we should not be taking it as a, as per me, as a infective thing. All this is inflammatory marker only. So this thing at is a worsening of this condition. Anything, madam, from side?
Just like, I'm just having a problem with my net, and then I'm sorry about it. And it's very, very a good marker, like, for inflammation, as you said, like, it's a indicator of severity. And then it's definitely, we have to do procalcitonin, and also subsequently it says infection setting in the pancreatitis also. So we have to be very careful. At this juncture, what are the other investigations you want to send?
At this point of time,
Can you hear me?
yes, ma'am. At this
Yes.
point, since he had already, we have already diagnosed him as acute pancreatitis, but the etiology we couldn't be certain of because he had no alcohol history, and his ultrasound abdomen was also normal. So at this point of time, we will like to send the lipid profile to look at his triglyceride level.
Okay, fine. So what do you expect in the triglycerides, like, because he's not so obese, you said, he's moderately built.
We expect...
Okay, so... Hello?
Hello?
Can you hear me?
Yeah, yes, ma'am. Yes, ma'am.
Yeah. Yeah. The thing is, like, so what is the other investigation you want?
So there is some disconnection. Yeah. Hello? Yeah, madam. You're
Yeah,
not
me?
audible, ma'am.
Yeah.
Yeah, now you are audible, ma'am. Yeah. There was disconnection happened in between.
I'll join you as well.
Yeah, I think madam left. She may rejoin again.
Okay,
Yeah,
okay.
yeah. Dr. Durgesh, you want to
Yeah.
continue?
So
Kaladhar, you can also join
Yes, yes.
Durgesh. Don't
Yeah. We'll continue. Yeah.
So at this
please do
point,
continue.
Yeah,
At this point of
madam
time-
has rejoined. Yeah, please, ma'am. Yeah. Okay.
Please go ahead. Durgesh, go ahead.
Lipid profile, and what about the calcium? Because we are not seeing any calcium value here. So hypercalcemia is one of the reason for pancreatitis now. So have you checked at that point?
Yes, sir. We did the calcium level here. I have not mentioned, but the calcium level, as well as the corrected calcium level, it came within normal limit.
Okay. Okay.
So what is idiopathic acute pancreatitis?
Idiopathic pancreatitis, ma'am, when we are not able to find the cause of the acute pancreatitis. So in that case, we can say the patient might be having idiopathic pancreatitis. Like if the patient has got any familial history or any anatomical pathology.
What is the relevant diagnostic test, like, you want to do in case, like, really want to rule out, like, biliary stones in this particular case, like where you want to establish the diagnosis of idiopathic pancreatitis? What's normally you do, and then what's the other thing you have to do to rule out?
First, ma'am, we have to do all the possible tests to see the cause of the pancreatitis or even take the relevant history, because sometimes the patient might have drug-induced pancreatitis as well. So if
Is there any role of endoscopic ultrasound and MRCP in this particular case? Like, maybe.
yes, if the diagnosis is not
Okay.
certain, then we
Yeah.
can.
Sure. So how about CT scan now at this juncture? You want to do or not do?
Yes, if the diagnosis is uncertain, then we should do one CACT abdomen. But in this patient, when he came to the ICU on the first day, we sent the LFT, and his triglyceride level came to be around 1,100. So
Oh.
yes, we already have established the cause of the pancreatitis, so that is why we did not go ahead with the CACT.
Okay, fine. So please go ahead. Go ahead.
Yes, ma'am. So as we can see, these are the serial ABGs that we did. His ABG kept deteriorating, vitals, it remained more or less same. And when we received the report of the triglyceride level, and it was 1,180, then at that point we started the injection insulin infusion IV at 0.1 unit per kg per hour. And we also initiated dextrose D25, dextrose 25 at 10 to 15 ml per hour to keep the blood sugar level between 140 to 180.
So you think this is triglyceride lipid profile, altered lipid profile contributing to your acute pancreatitis. Is it so?
Yes,
yes. So what's the role of CT scan when you want to do?
CT scan is ideally to be done between 72 hours to 96 hours from the onset of symptoms. And it's done, one we can do if we are not sure about the diagnosis. Second, we can do see for any complications of acute pancreatitis which is present in the patient.
Okay, fine. So this patient, you're going to manage with insulin and then dextrose, maintaining. So, is it very common, hypertriglyceridemia induced pancreatitis?
No, ma'am, it is not very common, and it is it is seen around 1 to 3% of the cases.
Okay, since he's deteriorating, and then you want to see the patient is having fever, and the procalcitonin is also going up, you said, and the WBC count, is it rising or staying much the same?
It was it was around 11,000.
Okay, 11,000, and so not too high. And then neutrophil count, neutrophil portion, is it increasing or decreasing? And then you check out and the band forms and everything to suggest what is suggested for infection. And when you have a doubt, and then you're suspecting some necrosis, what do you do next? For the establishing the diagnosis and seeing the severity.
There is a CT severity index.
You want to do a CT scan. What kind of CT?
Contrast enhanced.
CT. And now, what are you concerned about in this patient? You had all the investigation workup done. You want to do a CCT abdomen.
We can do CCT.
So what's the concern?
But ma'am, in our patient, after the fluid resuscitation as well as the insulin therapy, the patient started to respond. And as you can see the serial ABGs, his serial ABGs started to improve. And by second day itself, the patient started to show more improvement. And he even started to tolerate clear liquid diet. So we did not do the CACT abdomen.
Okay, that's great. I know. So he's improving, and you think it is only a mild and then not much of organ failure. It is resolved within 48 hours. So it's moderate pancreatitis. Is that so?
Yes, ma'am.
If in case he progresses further, so to severe pancreatitis, yes. And then so how do you manage this kind of patients? And then what's the tests you want to do? And subsequently, do you want to give antibiotics? Suppose the etiology is something different, and then he responded, fortunately.
Antibiotic.
didn't respond. Yes, want to give antibiotics in the first go or no antibiotics? Is there any role for prophylactic antibiotic because they spiked temperatures in the beginning?
The rise in the temperature that could be because of his SARS response, ma'am. And there is, as per the guidelines, there is no role of prophylactic antibiotic or any administration.
Very good. So there's no role for prophylactic antibiotics, and antibiotics are given only when there is a suspected infection, isn't it? And what are the antibiotics in case you have to choose, like, for this treating severe pancreatitis with infected pancreatic necrosis?
So
In fact,
preferred are carbapenems, fluoroquinolones, and then third generation cephalosporins for these cases.
And also we can give the metronidazole because
yeah.
they have more pancreatic tissue penetration.
Okay, fine. So these are, like, the ones which penetrate into the pancreas, but the problems of these again, resistance. So resistant Klebsiella. And finally, what's the role of antifungal treatment in this particular case? Like, if in case, not in this particular case, I'm asking you in infected persons, is there a role for antifungal drugs?
Antifungal, ma'am, if there is suspicion of any fungemia or the patient is not clinically improving even after the antibiotic therapy, then if the patient has got other risk factors as well of fungemia, then we can add we can give fungal coverage.
Mm-hmm. So what kind of fungal infections do you expect in these cases?
It is Candida species are involved.
Yeah. Candida albicans is the most common, and then Tropicalis and QC, and some patients, like, are really immunocompromised, but like most often it is Candida albicans. Okay. And so so what else, like, how did the patient progress further?
Then his vitals improve on day 2. His breathing became his respiratory rate, it came down from 36 to it became to 26 to 28. Then saturation or even on nasal prong, he maintained saturation above 90%, and
So
his
you
heart rate also
extubated
it
him.
came down.
You extubated him,
Ma'am,
is that?
the patient was on NIV, ma'am, since the first day. Although
Oh,
the
you didn't put
patient
him
had
on ventilator. Okay, fine. Okay.
then his heart rate on day 1 he had up to 160 per minute. Then on day 2 it came down to 110 to 130. Then his fever also subsided, and the triglyceride, uh, the BP also it improved. Then since he improved and he showed some improvement, then we taper off and we discontinued the norepinephrine. Then we continued the same IV fluid at 80 to 90 ml per hour. And although he was maintaining saturation with nasal prong, but still we kept him on intermittent BiPAP because he still had increase in respiratory rate.
So how about the nutrition?
On second day, ma'am, we started him with clear liquid diet because he had no nausea and no vomiting.
So in NIV, you wanted to give him feeds and then, like, get going. Is that?
Ma'am, we gave intermittent BiPAP. So in between the BiPAP therapy, we gave him clear sips of liquid diet.
Okay. So what's the role of early enteral nutrition?
Yes, ma'am. It is better to start the enteral nutrition as early as possible if the patient doesn't have any vomiting or any regurgitation or any abdominal distension. It will maintain the gut integrity of the patient, and it will also help to decrease the secondary infection.
So what kind of feeds, like, you want to give oral or nasogastric or nasovaginal, or like, in this patient with an IV, what would be the best, like, for this kind of patient?
If patient is able to tolerate his diet orally, so we can start him on oral diet, or we can also secure a tube for this patient and continue diet through that. And diet for him will be high caloric, high protein, and low fat diet.
Okay, fine. So, so how about nasogastric and the nasovaginal? Like, do you prefer that? And then if in case, like, the patient is not able to eat orally?
Nasovaginal tube is generally preferred if patient has any gastric outlet obstruction.
If not, then we will go.
Nasovaginal if gastric outlet obstruction. So is there any difference between nasogastric and nasovaginal feeding?
Yes, ma'am, there is a difference because
According to the evidence.
It is nasogastric feeding is non-inferior to nasovaginal feeding, ma'am. So
exactly, there is no difference like in the outcomes, they say. But in practice, like if the patient is not tolerating nasogastric, then you may have to put in the tube a little further down.
So you have to put, suppose, what is the other way of treating this? Like you have started an insulin that is responded is very well. So what is the role of plasma apheresis or plasma exchange?
we can do plasma exchange, but since on the first day the patient even did not give consent for mechanical intervention in view of financial constraint, but it did not. I mean, if the insulin did not show any improvement, then we could have initiated the plasma exchange therapy.
Yeah. So plasma exchange is one of the options. Once the levels are come down less than 500, then you can discontinue the plasma exchange as well as insulin. So we are discussing regarding the feeding. How we'll optimize the feeding. So first is always should be if you are tolerating, oral feeding should be the priority. If not, then probably nasogastric. If not, nasovaginal. So as there is no any difference as per se which are nasogastric or nasovaginal, but in case if he's still not tolerating, then you have to put a nasovaginal. So always enteral feeding is always a priority. So what is the suppose patient still is not tolerating? Will you start early parenteral feeding?
So yes, we'll wait for 5 to 7 days.
So what is the need trial of enteral plus early parenteral versus enteral plus late parenteral? Late in the sense probably after probably 4 or 5 days, or only enteral nutrition?
Sir, we're not ever of any study.
So it is always enteral. You have to see enteral feeding. Initial days you have to always try enteral feeding. If not, both if you are combining with the parenteral, then the complication rate usually goes high. So always prefer for oral. If not, then enteral you have to continue.
So what is the difference between nasovaginal and nasogastric?
Sir, the nasogastric, the feeding it goes to the stomach, and the jejunum. Suppose if the patient doesn't tolerate, or if the patient has got symptoms of sign and symptoms of gastric outlet obstruction, then we pass the tube with the help of gastroenterologist till the jejunum, so that the obstruction is bypassed.
Is there any difference while feeding with these different routes in the patients? Any recovery differences in terms of improving the overall benefit of nasogastric versus nasovaginal? Generally, across studies, it did not show much of any difference between these two routes. But of course, if there is a lot of ileus and if the pain is still persisting, some people, a small study showed nasovaginal route may be better in this subset of patients. What is the problem in starting parenteral nutrition in your particular case?
The problem, the patient, we kept him on NIV therapy, and the patient also on the first day he complained of nausea, although some on subsequent days he did not have any.
No, the question is, if you want, suppose if the nutrition intervention is getting delayed because of lot of ileus and all, do you consider parenteral nutrition in your particular case? If you consider, what are the problems that you face? What is the etiology of your pancreatitis in this patient?
Etiology is triglyceride-induced acute pancreatitis.
What is the problem with parenteral nutrition?
Parenteral nutrition, if we are going to give, it is going to be mixed with the carbohydrates, protein, and fats are going to be there.
So you are giving lipids directly infusing. It's a lipid component will be there. So most of the times what happens is if it is a, of course, recently we are getting the supplemental parenteral nutrition without fat component. But if you are considering fat component, already triglycerides are on the higher side. So it can worsen the pancreatitis, especially in this particular case. So if you contemplate starting nutrition, if it is enteral, what formula you go for? What is the preferred prescription? I can say, what is the nutritional prescription in this patient?
Calories intake we target is around 25 to 30 kilocalories per kg per day, and protein target is 1.5 to 1.8 gram per kg per day for this patient.
Very good. Okay.
How about a
fat.
polymeric or a peptide formula?
We will go with polymeric formula.
Polymeric, like, in pancreatitis, better to use a peptide formula in the initial phase and subsequently go with a peptide polymeric formula. Okay. So peptide formula also should be kept in mind, like when you're treating pancreatitis, because of the enzymatic problems and then digestion problems. All right. So go ahead, Kaladhar, go ahead. I just intervened.
Yeah, no problem. Yeah.
So, like, what is how will you classify nasovaginal and what is the anatomical landmark? So, where you see it is a nasovaginal and where you see it is nasogastric. So, anyway, if you have to put a nasovaginal, you have to take help of your gastrocolic. It is probably like component of trees is going beyond that, then it is a nasovaginal. Okay. So, these patients who are not still like ileus and all, you can try nasovaginal also.
Okay, in case like, surgery is required, like it's not, though not in your case, maybe in severe pancreatitis, severe acute pancreatitis, when do you call your surgeon friend?
If the patient is deteriorating clinically, or the patient is showing new onset of a new organ dysfunction or organ failure, and like if we are doing CACT of the abdomen, and if it is showing infectious etiology in the pancreas, I mean the infectious necrotizing pancreatitis, and if the patient is not responding with antibiotic therapy as well.
So ideally, ma'am, we give at least 2 weeks of antibiotics, and after that, if any response is not there, then we can opt to think for surgery. And that too, in surgery, we will prefer minimally invasive surgery.
Yeah. So usually, like, the endoscopic guided surgeries are like, more valid. So definitely, like, the open surgeries are not at all like indicated, and they're associated with very high mortality. So even if the surgeon, like, you should be a conservative surgeon, like, you should calling in. Otherwise, like, if he opens and then the patient will go dead. So you should be very careful, like, nowadays more conservative approach. What are the indications for surgery, like open abdominal surgeries in these particular cases, like maybe early or late, mostly late after 4 weeks? What are the indications for surgery, laparotomy?
Again, indication again, ma'am, if the patient, if the first minimal access surgery or the endoscopic interventions are not helpful and the patient is deteriorating, the patient even have deteriorating abdominal compartment syndrome, then we should think of open surgery or the help of our gastrosurgeon.
Any fistulas? And those are also the indications for like enteric fistulas, and they can develop as a complication, isn't it? Waldorf necrosis. What is this Waldorf necrosis?
It is the collection of the collection of the pancreatitis. If it is having a mature wall around it, then it is Waldorf necrosis.
It's seen after some time. What time? 4 weeks, isn't it? So if they're causing obstruction in the gastric outlet also, they're so big, and then maybe you have to intervene as surgeon and then asking for doing a surgery. And also bleeding.
Retroperitoneal.
Like, the patient starts to bleed. And because pancreas erodes the vessels and they start to bleed, maybe they have to subject them to laparotomy. These are the indications, like we have to call your surgical colleague, and then there's a team concept in pancreatitis management. Can you prognosticate a patient with pancreatitis?
Yes, ma'am. We can prognosticate. We can prognosticate like with all the clinical scores that we have. We can do with the calcitonin level, the CRP level that we had discussed earlier, and also the CT score.
See, all these, though they indicate severity, you can never prognosticate a pancreatitis patient. Like, be careful in the ICU, never give hopes to the patients like severe pancreatitis, especially a chronic ethanolic, and then the patients who have recurrent problems and they have chronic pancreatitis, acute and chronic, never prognosticate, because they can succumb. So what do you think, Dr. Your views? Kaladhar?
Yeah, yes, ma'am. Yeah, that's true.
Uh,
So these patients do have a lot of ups and downs, and most of the times they'll end up in complications, local complications, necrosis, infection, and systemic complications like abdominal compartment syndrome, ARDS, anything. So I think probably we did not discuss about abdominal compartment syndrome, ma'am. Yeah. So what do you think, Abhishek? Suppose this patient developed a lot of ileus, underlying severe necrosis. So, and patient developing hypotension, tachycardia, and when there is a suspicion for abdominal compartment. So what is the definition, basically, abdominal compartment syndrome?
Abdominal compartment syndrome, it is defined as a sustained intra-abdominal pressure above 20 millimeter mercury, along with new organ dysfunction.
Yes.
Okay.
So abdominal compartment syndrome, is definitely surgical, you have to decompress as fast as possible, and then you have to do something. Otherwise, the patients will develop problems all over the body, isn't it? So it's a multi-organ system involvement subsequently because of the intra-abdominal pressure. So it's very important you diagnose and then immediately treat. So whenever you can prognosticate. Dr. Durgesh, what do you think, in this?
Yeah, so main thing, as suppose if the patient is not improving even after initial year, so you can think of any infective pathology. Here you see contrast enhanced CT. How will you find out necrosis? So you are thinking of necrosis. How will you find out whether the patient is having patient is having necrotic pancreatitis or it is a plain edematous interstitial pancreatitis? How will you know?
Edematous interstitial pancreatitis.
Ah.
There will be enhancement of the contrast in the pancreas, so that will give us a clue of edematous pancreatitis.
And when will you say there is a necrotic pancreatitis?
Pancreatitis, if we look at the timeline of the onset of the symptom as well as a radiological finding, like there is no enhancement, then we can say there is necrosis. We can think of necrosis.
So if there is no enhancement on the contrast, then it is probably necrosis. When you will say suspected infection in contrast,
if there is intraluminal gas.
Okay, so if there is intraluminous glass formation, then there is a high probability that you are dealing with infected necrotic pancreatitis. What could be the morphological classification of pancreatitis? So initially we did severe depending upon the organ dysfunction. What could be the morphological in the sense?
Edematous pancreatitis. Then we have cirrhosis. Then we have a necrotizing pancreatitis. Then walled-off necrosis and infected pancreatitis.
And
what is Balthazar score?
Yeah, what is the Balthazar scoring system?
Balthazar score is the CT severity score. Then we have two scoring system. One is according to the necrosis, and another is according to the involvement of the edema.
So, necrosis and inflammation, collections.
So when you will say that it is a mild, moderate, and severe pancreatitis, depending upon the necrosis.
If the necrosis is less than 30% of the pancreatitis, pancreas parenchyma, then it is mild, and if it is 30 to 40%, then it is moderate, and if it is above that, then it is severe pancreatitis.
This is as per as Balthazar, like how will you differentiate any morphological is difference between pancreatic pseudocyst and wall of necrosis?
So pancreatic pseudocyst will have a non-epithelial layer of granulation tissue around it, whereas walled off necrosis will consist of a inflammatory wall which will be consisting of epithelial tissue.
Both are covered by inflammatory wall only, both are, but what is the difference? The pseudocyst, there is a minimal or no necrosis. Okay, in wall of necrosis, obviously there is a pancreatic or peripancreatic necrotic fluid has accumulated. Later on, it has completely walled off. Usually, both of these complications usually seen in later on date, more than 4 weeks, the onset of the disease. So what are the different etiologies apart from this triglyceride, hypertriglyceridemia? What are the different etiologies of the pancreatitis?
Most common etiology of pancreatitis is gallstone disease, then followed by alcohol. Then we have hypercalcemia. Then we have drug-induced acute pancreatitis, and we have infected etiology as well, like mumps, Coxsackie, CMV virus, and then herpes simplex virus. Then we even have
Blunt trauma
abdomen.
Blunt trauma can be there, and then ERCP-induced pancreatitis can also be seen.
Okay, any bacterial infection specifically correlating with the pancreatitis?
So most common bacteria are gram-negative bacteria, and it is Klebsiella, Pseudomonas, and Enterococcus species which are seen.
No, you will get these organisms when this necrosis will get infected. But probably in leptospirosis or salmonella infection, or probably in mycoplasma infection, you may get secondary pancreatitis. You are talking about the drugs. What drugs are implicated? Commonly used drugs.
The commonly used drugs are hydrochlorothiazide, then valproic acid, then
6-mercaptopurine is there. Then we have
and
any antiretroviral?
Antiretroviral.
And in
Which retroviral?
sulfonamides, they are very commonly implicated. Steroids, sulfonamides, diuretics, tetracycline group of basically they are metabolites of tetracycline have been implicated. Valproic acid metabolites have been implicated in pancreatitis. Steroids, a lot of immunosuppressive drugs are also implicated in. So estrogen therapy is also implicated in the pancreatitis. What are the other local complications apart from what you have mentioned?
There could be splenic or portal vein thrombosis in this patient.
Okay.
This can be there. We can have a retroperitoneal hemorrhage also.
Okay. Any aneurysm, vessel aneurysm, gastroduodenal vessel aneurysm, artery aneurysm is also one of the known complications.
in mesenteric ischemia. Then we can also have acute cholangitis.
Okay. So tell me about gallstone-induced pancreatitis.
So
What specifically, what investigation, what lab parameters will indicate towards the gallstone pancreatitis, and what is the how will you proceed, and what is the treatment options?
So gallstone pancreatitis will have deranged liver function test in these patients with the elevation of our bilirubin derangement will be there in this patient. Then we can get a USG abdomen also done to see gallstones. And if it is not there, we can also take help of MRI in this patient, as gallstones are better seen with MRI. And other things we can do is endoscopic ultrasonography, or we can go for ERCP also. In ERCP, we can do the stenting, or we can do sphincterotomy to release stones.
So usually in gallstone pancreatitis, what you get is alanine trans aminotransferase is elevated, more elevated compared to aspartate aminotransferases. That is one point. And as already discussed, ultrasound is the preferred modality to see whether the gallstone or impacted gallstone pancreatitis along with your elevated enzymes. This points towards the diagnosis. Considering it, whether when to do ERCP in this situation is again a controversial question. So when will do ERCP in patient with
Yeah.
gallstone pancreatitis?
Patient is having cholangitis, then we can.
If the patient has acute cholangitis or any signs of biliary obstruction, then we can go ahead with the ERCP in like within 24 hours or within 48 hours.
Is okay within this if you are having cholangitis and there is an ongoing obstruction like bilirubin is elevated, if more than 4 milligram per deciliter, then you have to consider early ERCP within 24 hours.
Definitely.
Okay.
So how about pancreatitis, gallstone pancreatitis? When do you suggest cholecystectomy?
Cholecystectomy, if the patient has got gallstone-induced pancreatitis, in the initial phase, we will not suggest the cholecystectomy. Once his acute condition has been stabilized and he's not in SIRS anymore, then before discharge, we can suggest him for cholecystectomy.
So which are the places, if the patient is having severe acute pancreatitis with all the pancreatic necrosis and all that, do you suggest him at the time of discharge, you want to go cholecystectomy?
We wait for 4 to 6 weeks for inflammation to settle and then recommend.
So you should not subject such kind of patients to cholecystectomy because you'll have land up with infections related problems in this kind of patients. So only for patients who have been off the inflammatory markers, then at the time of discharge is the best to prevent recurrent gallstone-induced pancreatitis. Yes, definitely. So Dr. Durgesh, yeah, anything more and then, or we should conclude?
Yeah, just almost only a few points like in during resuscitation. So there is always whenever the pancreatitis and all. So first thing is that we have to have scoring system. So to label it as which category it fall, and accordingly we should prognosticate it. Regarding fluid resuscitation, as already discussed, it is like a ringer lactate. Studies have shown that ringer lactate is preferred compared to the normal saline only in conditions of hypercalcemia induced pancreatitis, where the ringer has itself is a calcium. There we can switch over to probably normal saline. And there is a called as conservative versus aggressive resuscitation. There is a studies that probably 7 to 10 ml per kg body weight bolus and continuous resuscitation versus 1 to ml per kg body weight fluid as a maintenance, and in between 10 ml per kg. So both has a equal weightage, and both but in aggressive fluid there are high chances of pulmonary edema. So we should be more concentrating on conservative fluid nowadays. Conservative fluid strategy is more toward practiced. So organ failure is again a problem where persistent organ failure, if any form, will again point out towards the severe pancreatitis and have a probably stormy course.
Yes.
Yeah, I think as Dr. Durgesh said that trial called as ERICA trial, where they concentrate on conservative, less restrict, like more restricted fluid given compared to liberal fluid. But I think one nuance of that study is if you look at the limitation the patients who are involved in the study are more of moderate pancreatitis. I differ here where the patients who are coming with severe tachycardia, tachypnea, initial extensive necrosis, probably they have a lot of third spacing. Probably, I think we have to take this study with pinch of salt, probably go for aggressive fluid resuscitation in the initial periods, especially the patients who are coming with severe probably moderate pancreatitis. I think we can apply this restrictive fluid strategy. And any other things, ma'am? Suhasini, ma'am?
No, actually, though it is done in moderate, even some studies are done in severe pancreatitis also. They're initially you treat, but subsequently you have to hold. The same concept as in sepsis also. So definitely, you have to individually tailor to the need of the patient rather than go aggressive or not. It depends upon how the patient responds and then what's the kind of organ failure he has, and then all these problems. And then these hypertriglyceridemia, again, ARDS is one of the components, is this patient already had? And then we have to think about early plasmapheresis, maybe if it didn't respond to definitely the treatment. And pancreatitis never prognosticate, and it has got a lot of complications. And then the ward of necrosis and all that can get infected, and subsequently pancreatic abscesses, and then even the cirrhosis extend into the thoracic cavity also we've seen, and then they're causing compression in the heart also. So these are not very simple disease, it's a complicated form of disease, and then which affects the various organ systems, and we have to be very careful prognosticating also. And the most controversial things are the enteral nutrition, and then you have the antibiotic therapy, surgical interventions, and nowadays the step-up protocol, for interventions. First, you go in for a more endoscopy. Yeah. Dr. Durgesh?
No, step-up protocol, yes, it is nowadays it's coming up. So that is
initially conservative, later probably minimally invasive pancreatic necrosectomy is the standard. Yes, ma'am. Yeah, regarding some questions, ma'am, we'll take some questions. Regarding pain control, especially one of the audience is asking about the role of epidural in pain management, and when to go for it and when to avoid. Dr. Avishek, madam, yeah. Suhasini, madam, please.
Yeah, he can talk. Let them talk. Children, let them talk. No issues. And tell me, Abhishek.
Yes, ma'am. Initially, we should not start with the epidural analgesia. We should start with multimodal analgesia. Like we have options paracetamol, this tramadol, or we have even option fentanyl. Morphine, we should be cautious because morphine can cause constriction of the sphincter of Oddi, which can aggravate the already ongoing pain abdomen. So if all these therapies fail to decrease the pain, then we should think of epidural analgesia as an option.
So the thing is, the epidural analgesia, though practically, theoretically, they say it's very much beneficial when compared to the analgesics, which have their own consequences. But it's a little cumbersome in the presence of severe pain, the patient positioning, and all the other things which have to be taken into account, like the expertise of the person performing it and everything in the presence of bad posturing. It's really hectic, putting in an epidural catheter. But theoretically, it has got its own advantages. The gut perfusion is better, and the pain relief is very good, with epidural analgesia. So you can give a continuous epidural, adding things to potentiate the pain relief, and a lot of things you can do. But still, it's one of the modalities. But to take it if you're a real expert, you can definitely put in a catheter. What do you think, Dr. Durgesh?
Yeah, I think opioid-based analgesia is always preferred therapy. So as you have to start with the a fentanyl low dose or fentanyl patches also, and so again meperidine is a very short acting. You can be used. Morphine, as again there is a dysfunction, but it can be used. But epidural catheter is theoretically feasible, but it is difficult to implement because patient is already having so much of pain. So mainly it is analgesia should be opioid based.
Yes, yeah. So, yes. So another question is, what antibiotics do you prefer? Yeah, Dr. Suhasini madam.
Yeah, like the ones which have a good penetration into the things, and then so usually the aminoglycosides are no to this kind of, because they don't penetrate well. And third and fourth generation cephalosporins, like they have moderate penetration, and because the lot of ESBLs, and then we have to pick and choose like which is the best combination for this kind of patients. And if you have a culture got from the FNAC done from the necrotic material, and then you do the culture, and then guided therapies are the best, of course. And then carbapenems again, like they say the penetration is very good, and then we also give a lot of carbapenems to this kind of patients. And now, like the KPCs and like the metallo-beta-lactamase is coming up in a big way, so we have to be cautious. And then like the culture-based therapies, and then empirically you start like but wait for the cultures, and as soon as you get the cultures, and then nowadays lot of molecular things, and then like PCRs and all are available. Maybe we should make use of them for getting the early results, and then like tailor the antibiotics according to the need. And then the de-escalation of antibiotics is also very, very important. That's what I feel like in this case also.
Yeah. Yes, ma'am. So one more question. Hello, ma'am. Hello.
Tell me.
Yeah. Dr. Durgesh, you have
Tell
one
me. I can hear you.
Yes, ma'am. Yes, ma'am. We can hear. One question to Dr. Durgesh. How reliable is focus, especially looking at IVC variability when patient is having severe tachycardia and tachypnea?
Yeah, usually in this situation, like again, focus is a modality where definitely a lot of factors are at interplay. Interpretation becomes very difficult. So, like if the patient is having severe tachypnea, patient is having wholly look reliabling on IVC, it is very difficult. So on total, what I'll suggest is don't go means a fluid response when it is not related to just IVC, because when nowadays ultrasound is available everywhere, you can have practice, you can have different protocols as well. So if the A profile is there, okay, if the IVC is you are not able to just check and bilateral lung. If it is A profile, that's why you are dealing with a dry lung. So you can give fluid resuscitation. Then that is you can use a different protocols like blue protocol. Forget about that. There is a protocol called as false protocol also. So false protocol indicates that fluid administration limited by lung ultrasound. So here what you see, if you are giving a fluid, so but your lungs are dry, till that time you can give the fluid. Only main thing is that patient should not land up in pulmonary edema. If there is appearance of the B line, that means that you have reached the mark and you are already flooding with the pulmonary capillaries. So at that point of time, you have to be reduced or you have to be very cautious. So only going for by IVC is very like not probably not a very good thing. You have to take care of other thing also. So here then we have to have other different hemodynamic parameters. You can take it off. So you can have like probably arterial line in situ and also you can make use of all these things. That is why previously I mentioned VTI, velocity time integral. So because it is very difficult to solely rely on IVC.
Yeah. So I think with that, I think we have come to the conclusion. I think one more question is relationship of insulin in triglyceride-induced pancreatitis. Dr. Abhishek, do you want to answer it?
Yes, sir. First, we have to look at the how this triglyceride causes pancreatitis. Triglyceride, after its metabolism, it releases free fatty acid as well as the chylomicrons. So they increase the viscosity of the pancreatic duct, and then subsequently it causes pancreatitis. So what does this insulin does? It increases the metabolism of triglyceride through its hormone sensitive lipase enzyme, and also it increases the absorption of free fatty acid into heart muscle, then white and brown adipose tissue. So that's how the insulin lowers triglyceride level.
Yeah, right. So very good. So I think we have come to the end of our session. Dr. Suhasini, madam, any final comments from you? Tips to the students, because you are a very senior teacher, very regularly. You have seen so many students in your career.
Yeah,
Please.
yeah. Thank you very much for involving me here. I'm very sorry about the net connections. And anyway, and it's a very good presentation, Dr. Avishek and the colleague. I wish to congratulate them both, and then they did a good job. And also, like, managing patients, patient also, like, they did a good job. I appreciate that. And also, one more thing we forgot is that pancreatitis in pregnancy is very, very common of late, like, and then we had to, because of the hormonal changes and the cholestasis is very common. And they tend to have more pancreatitis, and then we have to keep it in mind whenever they present with pain abdomen, or these reduction levels also tend to be higher, and then all this we have to keep in mind while managing pain abdomen in pregnant patient. So this is what like that. And so as already we discussed, the fluid resuscitation, the antibiotics, timing of surgery, and the role of CT scans, MRIs, and the endoscopic ultrasound, everything has been discussed. And hope the students have benefited from this thing. And I'm very happy for these lecture series. I also listened to a few of them, but most of them are very, very good and very informative. And I congratulate Dr. Venkat and you and all your colleagues, and then get going with the lecture series, and then which is of great benefit to the students. I'm very happy about it. Thank you very much.
Thank you. Dr. Durgesh, any final comments from you?
No, indeed, pancreatitis is very seems to be plain simple case in exam point of view, but your Viva or your discussion may go in any topic like fluid resuscitation, ARDS, abdominal compartment. It really stays in the pancreatitis. So it is it will cover everything, almost all critical care. What everything will be asked in the examination. So anyway, it is really I spoke. It is really good discussion where we also learn a lot of things. Not only students. We also learn a lot of things. Thank you.
Yeah, thank you, Dr. Durgesh.
Yeah.
So I think thank you very much, Dr. Suhasini Madam and Dr. Durgesh, for sharing your clinical insights. I think it's an extensive session, almost 1.5 hours. And Dr. Avishek and Dr. Nikita for presenting the case and for the elaborated discussion that happened subsequently. And I thank Yashoda Hospitals and our digital team and our branding team for providing the platform for regularly discussing these cases. Thank you. Thank you, everyone. Good night.
Thank you. Good night, everybody.
Thank you, sir.